So hello, my name is Helen. I'm the extended physiotherapist practitioner working in the minor injuries at the Leicester Royal Infirmary. This is Dr. Shahid, the associate specialist also working in minor injuries. And we're here to show you how to initially manage a patient who has a mallet finger injury and to apply the mallet splint.
Yes, when the patient arrives and once you have diagnosed mallet finger, patient will require always X-ray in AP and lateral view. If there is a small avulsion of the base of the distal phalanx, then to apply mallet splint is appropriate, and this patient should be followed up in review clinic. However, if there is a big bony fragment more than 50%, that patient would still require mallet splint, but referral should be made to fracture clinic for further management.
So if we use Dr. Shahid as a patient and he has injured his right middle finger with a mallet finger injury, with a mallet finger injury there is damage to the extensor tendon on the finger at the DIP joint. It can just be the extensor tendon, or it can be an avulsion fracture at the bony insertion at the distal phalanx, but presents with flexion at the DIP joint. What we need to be able to do is keep this finger joint in extension for 8 weeks in a mallet splint. So if we can extend the finger, and we're going to get you to pop it down onto the table. So it's important as we are applying the splint to keep the finger into extension. Here we have a box of mallet splints of all different sizes, from size 1 to size 6. So we can just show you the differences in size. Obviously it's important to find the right size to fit the finger appropriately. For Dr. Shahid's middle finger, we have found that size 2 is the right size. We will just check that by placing the mallet splint over the distal end of the finger, and you can see that the shape of the splint holds the DIP joint in extension. It is important that the splint does not cover the PIP joint, as we do need to have flexion of that joint when the splint is fully applied.
However, in the application of a mallet splint, sometime to a little finger or index finger, the PIP joint is covered and we cannot move the PIP joint. In that case, we will have to cut the mallet splint and improvise it. We can remove it and we can cut with the scissor. And in order to make the edges smooth, just you have to apply the elastoplast tape around the edges so that the finger is not traumatized with the splint edges. And this is now smooth, and you can apply now back. And here it is. We have improvised the thumb. We have improvised the splint, and patient can move the PIP joint.
The splint here is made out of plastic, and it does have some air holes to allow breathing of the skin, but often patients return having worn the splint for a number of weeks with soft whitened skin areas because of the perspiration of the skin inside the splint. Because of that, it's quite useful to use a piece of gauze between the skin and the splint. So if we just cut a thin piece of gauze, lay it over the top of the finger to protect the skin, and then the splint should slide nicely on the top. You can see here the PIP joint is kept free to flex. And then using zinc oxide tape or micropore, the splint can be taped at its base just to hold the base of the splint onto the finger. If you just hold your hand up like this, please. So we can see that the DIP joint is held in extension, but we can flex at the PIP joint. So once the splint is applied, we do have an advice leaflet on mallet finger injury that we would provide to the patient. The patient will be kept in the splint for 8 weeks, so I would advise the patient that you are going to keep this on in total for 8 weeks. But after 4 weeks, we would like to see you again in our review clinic. We will give you an appointment, and we will just look at the skin condition and advise you on further care of your finger. During the first 4 weeks, we would like you to take the splint off on a daily basis to clean your finger. So to clean your finger, I will show you on the other hand. You're going to remove the splint, keeping the finger straight on a table. Then if you hold the end of your finger, so do you want to use this one to hold the end of your middle finger on that hand, and you would take your hand to your sink, holding the end of your finger, place your finger down in the sink, on the bottom of the sink, and then you can put water on, soap, wash your finger. And remember to hold the end again, so lifting it up again, and take your hand back to a table where you can rest it back down in extension, relaxed on a table, and dry your skin. Okay, you can stay there for a few minutes to let the air dry the skin also, before reapplying the splint in the same manner as we have first applied. So at 8 weeks post-injury, the patient will return again to the review clinic, where we hopefully will fully remove the splint. So if we can, do you want to take the splint off yourself? It's sometimes easier to remove the tape yourself. That's it. So initially, still remembering to keep the DIP joint in extension. So lay your finger flat and we'll take off the splint. And at this point in time, we are now looking to see, have we got healing and can the DIP joint maintain extension on its own? So if I ask you with your index finger to lift your finger up off the table, and if I hold the mid phalanx and I'm going to push onto the distal phalanx, you're going to maintain the position.
Okay.
So hold it in extension, which he can obviously maintain. This is the test I'm going to do for the injured finger. So if you can lift the middle finger, and if you can keep the distal phalanx straight as I apply a small amount of pressure, and you can obviously maintain extension. We'll pop it back down. If that is the case, this is obviously good news, and we would like to remove the splint completely and now need to commence finger flexion at this joint. So I'd ask the patient to turn their hand over, and using their other hand, if they pop the thumb underneath the DIP joint crease and just actively flex the tip of the finger. We do not want you to be pulling the finger into flexion, so it's just active flexion, and then ask them to bring the whole finger, flex at all joints as best possible down to the palm, and then fully straighten. And this will start their flexion rehabilitation. Should, when you test the extensor mechanism, the resistance, there's a slight extension lag, so they're not held in full extension, this does not mean you cannot remove the splint. The splint can still be removed, and we still need to start commencing flexion exercises as explained earlier. If the patient is stiff or weak in the joint, they can then be referred to hand physiotherapy service. So that was a quick demonstration for you on applying a mallet splint for a finger injury. If you have any further questions or further information, do not hesitate to ask somebody in the minor injuries department.